are used by most tissues for cell-to-cell communication. So they actually play an important role in the autonomic and central nervous system. So there are several peptides that exert important direct effects on the vascular and other smooth muscles. So you have your vasoconstrictors like your Angiotensin II, your Vasopressin, Endothelins, the neuropeptide Y, and your Angiotensin. And you have vasodilators. So if you have vasoconstrictors, you have vasodilators, and these are your bradykinins and related kinins, your natriuretic peptides, vasoactive intestinal peptide, substance P, neurotensin, calcitonin, gene-related peptide, and your adrenomedulin. So this is actually the steps in the enzymatic cleavage of your angiotensinogen. So basically, the principal steps includes your enzymatic cleavage of your angiotensin I from your angiotensinogen by renin to conversion to your angiotensin I. Then it is converted to angiotensin II by your converting enzyme, angiotensin converting enzyme, and the degradation of your angiotensin. So renin is an aspartyl protease that specifically catalyzes the hydraulic release of the decapeptide angiotensin I from your angiotensinogen. It is synthesized as a prohormone that is processed to prorenin, which is in an inactive form, and then it is processed to an active renin, which is a glycoprotein consisting of 340 amino acids. So they are found in the circulation, and those that are found in the circulation originates from the kidneys. So within the kidney, renin is synthesized and then stored in the juxtaglomerular apparatus of the nephron. So the juxtaglomerular cells are the site of synthesis and storage and release of your renin. So the macula densa is a specialized tubular segment associated with in the vascular components of the juxtaglomerular apparatus. The vascular and the tubular components of the juxtaglomerular apparatus, including the juxtaglomerular cells, are innervated by your non-adrenergic neurons. So the rate at which your renin is secreted by the kidney is the primary determinant of the activity of your RAAS, or your renin-angiotensin system. So renin, the secretion is controlled by a variety of factors. So you have your renal vascular receptor, the macula densa, the sympathetic nervous system, and your angiotensin II. So the renal vascular receptor functions as a stretch receptor. So it will, if there is a decrease in the stretch of your of the renal arteries, this will lead to the increase in the release of your renin, or increased renin release. So they are actually located in these receptors are located in the afferent arteriole, in the juxtaglomerular cells. So stress-induced changes in renin release are mediated by the changes in your calcium concentration in the juxtaglomerular cells. So the macula densa contains different type of receptor. So they are sensitive to changes in the rate of the delivery of your sodium or chloride to the distal tubule. So if there is a decrease in the distal delivery, this will result in the stimulation of renin secretion and vice versa. Now, Potential candidates for signal transmission between the maculodensa and the juxtaglomerular cells include your adenosine, the prostaglandins, and your nitric oxide. So your sympathetic nervous system also play a role. So if you have maneuvers that will increase the renal nerve activity, this will cause now the stimulation of your renin secretion. While if you have renal denervation, this will result in suppression of the renin secretion. So norepinephrine stimulates renin secretion by direct action on the juxtaglomerular cells. So in humans, this effect is mediated by your beta-1 adrenoceptors. So the circulating epinephrine and norepinephrine act via the same mechanism as the norepinephrine released locally from the renal sympathetic nerves. Now, your angiotensin II inhibits renin secretion. So the inhibition may result from a direct action of the peptide on the juxtaglomerular cells. And this forms now the basis of your short loop negative feedback mechanism that controls your renin secretion. Now, in any interruption of this feedback with inhibitors of the renin-angiotensin system will result in stimulation of your renin secretion. So there are some agents that may alter the release of your renin. So renin release is altered by agents like your hydralazine, minoxidil, or nitroprusside, which are vasodilators. They may also be altered by your adrenoceptor agonists like your beta adrenoceptor agonists, your beta adrenoceptor agonists, as well as your phosphodiesterase inhibitors, and most of your diuretics and anesthetics. So angiotensinogen is the circulating protein substrate from which your renin cleaves your angiotensin I. So it is synthesized in the liver. It's a glycoprotein with a molecular weight of approximately 57,000. The production of your angiotensinogen is increased by corticosteroids, estrogens, your thyroid hormones, and your angiotensin II. It is also elevated during pregnancy and in women taking estrogen-containing oral contraceptives. So the increased plasma angiotensinogen concentration is thought to contribute to hypertension that may occur in these particular situations. Your angiotensin I contains the peptide sequences necessary for the actions of the renin-angiotensin system, but has little or no biologic activity. So it must be converted to angiotensin II by your converting enzyme. So it may also may be acted on by plasma or tissue aminopeptidases to form your angiotensin I. So this is in turn converted to angiotensin II by your converting enzyme. So the converting enzyme is a dipeptidyl carboxypeptidase that catalyzes the cleave of dipeptides from your carboxyl terminal of your certain peptides. Its most important substrates are angiotensin I, which it converts to angiotensin II and bradykinin, which is in active form. So it also cleaves enkephalins and substance P, but the physiologic significance of these effects has not been well established. So the action of your converting enzyme is prevented by penultimate prolyl residue, and your angiotensin II is therefore not hydrolyzed by the converting enzyme. So your converting enzyme is distributed widely in the body. So in the tissues, the converting enzyme is located in the luminal surface of the vascular endothelial cells, and thus it has a close contact with the circulation. Your angiotensinase or your angiotensin II has a plasma half-life of 15 to 60 seconds, This is removed rapidly by the circulation by a variety of peptidases collectively referred to as angiotensinase. So it's metabolized during passage through most vascular beds, and most of the metabolites of your angiotensin II are biologically inactive, but the initial product of your aminopeptidase action is your angiotensin II, and this retains considerable biologic activity. Now, your angiotensin II exerts important actions at several sites in the body, like the vascular smooth muscle, the adrenal cortex, the kidney, and the brain. So the renin-angiotensin system plays a key role in the regulation of fluid and electrolyte balance and arterial blood pressure. If you have excessive activity of the renin-angiotensin system, this can result in hypertension and as well as disorders of fluid and electrolyte homeostasis. So angiotensin II is a very potent pressor agent. So approximately 40 times more potent than your norepinephrine. The pressure response to intravenous angiotensin II is rapid in onset, approximately 10 to 15 seconds, and this is sustained during long-term infusions of the peptide. So the pressure response to your angiotensin II, or to your IV angiotensin II, is due to direct contraction of vascular, especially the arteriolar smooth muscle. So angiotensin II can also increase blood pressure through actions on the brain and your autonomic nervous system. And the pressure response to angiotensin is usually accompanied by little or no reflex bradycardia, because the peptide acts on the brain to reset the baroreceptor reflex control of the heart rate to a higher pressure. So angiotensin II also interacts with your autonomic nervous system. It stimulates your autonomic ganglia, thereby increasing the release of your epinephrine and norepinephrine from the adrenal medulla, which facilitates the sympathetic transmission by an action at the adrenergic nerve terminals. So the latter effect involves both increased release and reduced reuptake of your norepinephrine. So it has little important direct positive inotropic effect on the heart. Angiotensin II also acts directly on the zona glomerulosa of the adrenal cortex to stimulate your aldosterone biosynthesis. So at higher concentrations, angiotensin II also stimulates glucocorticoid biosynthesis. Angiotensin II also acts on the kidney to cause renal vasoconstriction, as well as increase the proximal tubular sodium reabsorption and inhibit the secretion of your renin. Your angiotensin II acts on the central nervous system to stimulate drinking, which is called your dipsogenic effect, and increase the secretion of your vasopressin and adrenocorticotropic hormone, or your ACTH. Now, the physiologic significance of the effects of your angiotensin II on drinking and pituitary hormone secretion is not known. So angiotensin II is also is mitogenic for vascular and cardiac muscle cells, and also contribute to the development of your cardiovascular hypertrophy. So there are actually evidence suggesting or indicating that angiotensin converting enzyme inhibitors and angiotensin II receptor antagonists will slow or prevent the morphologic changes following myocardial infarction that would otherwise lead to heart failure. So angiotensin II receptors are widely distributed in the body. The receptors are located on the plasma membrane of the target cells, and this will permit rapid onset of the various actions of your angiotensin II. So there are two distinct subtypes of your angiotensin II receptors. You have your AT1 and your AT2. and they have been identified on the basis of their differential affinity for antagonists and their sensitivity to sulfhydryl reducing agents. So your AT1 receptors have high affinity for losartan and a low affinity for PD123177, which is an experimental non-peptide antagonist. While your AT2 receptors have high affinity for PD123177 and a low affinity for losartan. Isa, kadalila. Hello. Okay. Alayo na lang pagkuan pag orderihin may go home. Oo, may go home. Katapos, niya na lang pang meds kay may dapa ako lecture, ha? Thank you. Thank you. Bye-bye. So your AT2 receptors have a high affinity for your PD123177 and a low affinity for losartan. Your angiotensin II and serralacin bind equally to both subtypes. So AT1 receptors predominates in the vascular smooth muscle, and most of the known actions of your angiotensin II are actually mediated by your AT1 receptor, which is a G protein coupled receptor. So the binding of your angiotensin II to AT1 receptors in the vascular smooth muscle will result in the activation of your phospholipase C and generation of your inositol triphosphate and diacylglycerol, resulting in smooth muscle contraction. Now, the stimulation of vascular and cardiac growth by angiotensin II is mediated by other pathway, and probably receptor and non-receptor tyrosine kinase like your Janus tyrosine kinase or JAK2. This will increase the transcription of your specific genes. So the AT2 receptor has a structure and affinity to angiotensin II similar to those of your AT1 receptor. But the signal transduction by the AT2 receptor differs from the transduction by the AT1 receptor in that serine and tyrosine phosphatase, phospholipase A2 and nitric oxide and cyclic guanosine monophosphates are involved in the process. So your AT2 receptors are present at high density in all tissues during fetal development, but they are less abundant in adult, and they are expressed at high concentration in the adrenal medulla, the reproductive tissues, vascular endothelium, and parts of the brain. So the AT2 receptors are upregulated in pathologic conditions like in heart failure and in myocardial infarction. So what are the functions of your AT2 receptors? So this include fetal tissue development, inhibition of growth and proliferation, cell differentiation, apoptosis, and vasodilatation. So there are drugs that block your renin secretions. So it will block the renin secretion, the enzymatic actions of your renin, and the conversions of your angiotensin I to angiotensin II or angiotensin II receptors. So these drugs will interfere with the sympathetic nervous system as well and inhibit the secretions of your renin. So what are the drugs that will block the renin secretions involving the sympathetic nervous system? So these are your clonidine and your propranolol. So clonidine inhibits renin secretion by causing centrally mediated reduction in the renal sympathetic nerve activity, so that it will result to direct renal intrarenal action. While your propranolol and other beta adrenoceptor blocking drugs act by blocking the intrarenal and extrarenal receptors involved in the neural control of renin secretion. So there are two inhibitors that have been tested in humans, and they are the Renin and your enalkyrin. So they have high specificity for renin, so these are inhibitors. And this will cause marked suppression of your plasma renin activity and plasma angiotensin II concentrations, so that it will lower the blood pressure in hypertensive patients. So the bioavailability of these inhibitors is poor, mainly because of poor absorption and the first pass effect. So they will also increase plasma renin concentration because the interruption of the negative feedback of your angiotensin II on your renin secretion, further limiting the reduction in plasma renin activity. So renin inhibitors have potential to be effective like your converting enzyme inhibitors in inhibiting the renin-angiotensin aldosterone system, but further improvement of their bioavailability and efficacy is needed. So your converting enzyme inhibitors, they are an important class of orally active ACE inhibitors, which is directed against the active site of your angiotensin converting enzyme. So examples of your converting enzyme inhibitors are your captopril and enalapril. So these drugs differ in their structure and pharmacokinetics, but in clinical use, they are interchangeable, so they can be used either. So ACE inhibitors will decrease the sympathetic vascular resistance without increasing the heart rate, and they will promote natriuresis. They are also effective in the treatment of hypertension, decreasing morbidity and mortality in heart failure and left ventricular dysfunction after MI. And it will delay also the progression of diabetic nephropathy. So ACE inhibitors not only block the conversion of your angiotensin I to angiotensin II, but it also inhibits the degradation of other substances, including bradykinin, substance P, and enkephalins. So the action of ACE inhibitors to inhibit bradykinin metabolism contributes to their hypotensive action, and this is also responsible for some of the adverse side effects, including cough and angioedema. So your angiotensin antagonists differ from your angiotensin converting enzyme because you have substitution of certain amino acids, especially your sarcosine for the phenylalanine in position 8 of your angiotensin II, resulting in the formation of a potent peptide antagonists of the action of your angiotensin II. So the best known of these antagonists is your saralazine. So it exhibits some agonist activity and elicit pressure responses, particularly when circulating angiotensin II levels are low. Saralazine is administered intravenously, and this will severely restrict its use as an antihypertensive agent. However, you can use this for detection of renin-dependent hypertension and other hyperreninemic states. So the non-peptide angiotensin II antagonists like your losartan, valsartan, eposartan, irbesartan, candesartan, and telmisartan are orally active, potent, and specific competitive antagonists of your angiotensin AT1 receptors. So the blood pressure lowering efficacy of these drugs is similar to that of your enalapril. This is a typical ACE inhibitor, but it is associated with a low incidence of cough. So they are well tolerated, but should not be used by patients with non-diabetic renal disease or in pregnancy. So the current angiotensin II receptor antagonists are selective for your AT1 receptor. So prolonged treatment with the drug, this inhibits renin secretion and increases circulating angiotensin II levels. So there may be an increase in the stimulation of your AT2 receptors. So this may be significant in view of the evidence that the activation of your AT2 receptor causes vasodilatation and other beneficial effects. So your AT2 receptor antagonists, such as your PD-123177, are available for research, but they have no clinical applications at the moment. So the clinical benefits of your AT1 receptor antagonists are similar to those of your ACE inhibitors. So it's currently not clear if one group of drugs has significant advantage over the other. So kinins are a group of potent vasodilator peptides. So they are formed enzymatically by the action of enzymes known as your kallikreins or kininogenases acting on your protein substrates called kininogens. So based on your biochemical point of view, the Kallikrein-kinin system has several features in common with your Renin-angiotensin system. So kallikreins are glycoprotein enzymes produced in the liver as prekallikreins and present in the plasma and in several tissues, including the kidneys, pancreas, intestines, sweat glands, and salivary glands. So your serine proteases, they are serine proteases with active sites and catalytic properties similar to those of your enzymes like your trypsin, chymotrypsin, elastase, thrombin, and plasmin, and other serine proteases. So your plasma kallikrein can be activated to kallikrein by trypsin, the H-man factor, and your kallikrein cell. So in general, the biochemical properties of your glandular kallikreins are quite different from your plasma kallikreins. So kallikreins can convert pro-renin to an active renin. Your kininogens, these are the precursors of your kinins and substrates of your kallikreins. So they are present in the plasma, lymph, and interstitial fluid. So there are two kininogens that are present in the plasma, your low molecular weight form and the high molecular weight form. About 15 to 20% of the total plasma kininogen is in the high molecular weight form. The low molecular weight kininogen crosses your capillary walls and serves as the substrate for tissue kallikreins, while your high molecular weight kininogen is confined to the bloodstream and serves as the substrate for plasma kallikrein. So this is the Kallikrein-kinin system. So note that each of your kinin contains Bradykinin in its structure. So each of your kinin is formed from a kininogen by the action of different enzymes. So Bradykinin is released by the plasma kallikrein, your lysyl Bradykinin by glandular kallikrein, and your methylthionin lysyl Bradykinin by pepsin and pepsin-like enzymes. So the three kinins have been found in the plasma and urine. So Bradykinin is the predominant kinin in the plasma, while your lysyl Bradykinin is the major urinary form. So what are the effects of your kinins? So your kinin will produce marked vasodilatation in several vascular beds, including heart, kidneys, intestine, the skeletal muscle, and the liver. So they are approximately 10 times more potent on a molar basis than histamine. So the vasodilation may result from direct inhibitory effect of your kinins on your arteriolar smooth muscle or mediated by the release of your endothelium-derived relaxing factor or a vasodilator prostaglandin such as your PGE2 and PGI2. Now, the predominant effect of kinin on veins is contraction. So this may result from direct stimulation of the venous smooth muscle or from the release of venoconstrictor prostaglandins such as your PGF2A. So kinin also produces contraction of most visceral smooth muscle. So when injected intravenously, kinins will produce a rapid fall in the blood pressure. And this is due to their arteriolar vasodilator effect. So the hypotensive response to bradykinin is a very brief duration, so short lang. While the IV infusion of the peptide failed to produce a sustained decrease in blood pressure. If you need prolonged hypotension, this can only be produced by progressively increasing the rate of the infusion. So rapid reversibility of the hypotensive response to kinins is due primarily to reflex increases in heart rate, myocardial contractility, and cardiac output. So bradykinin also produces a biphasic change in your blood pressure. So initially, you will have hypotension followed by an increase above the pre-injection level. So the increase in blood pressure may be due to reflex activation of the sympathetic nervous system. Now, bradykinin can also directly release catecholamines from the adrenal medulla and stimulate sympathetic ganglia. It also increases blood pressure when injected into the central nervous system. So kinins have no consistent effect on the sympathetic or parasympathetic nerve endings. The arteriolar dilatation produced by kinins causes an increase in pressure and fall in the capillary bed, favoring efflux of fluid from blood to tissues. So this effect may be facilitated by increased capillary permeability resulting from contraction of endothelial cells and widening of your intercellular junctions and increased venous pressure secondary to constriction of veins, resulting now in changes in water and solute pass from the blood to the extracellular fluid, lymph flow increases, and your edema may resolve. So your prekallikrins and kallikrins are also present in several glands. As I've said, it can be found in the pancreas, kidney, the intestine, salivary glands, and sweat glands. And they can be released into the secretory fluids of these different glands. So the function of the enzyme in these tissues is not known. So the enzymes may diffuse from the organs to the blood and act as local modulators of blood flow. They may also modulate the tone of your salivary and pancreatic ducts and help regulate GI motility. It also influences the transepithelial transport of water, electrolytes, glucose, and amino acids and regulate the transport of these substances in the GI tract and kidney. It also plays a role in the physiologic activation of various prohormones, including proinsulin and prorenin. So kinins play also an important role in the inflammatory process. So kallikrins and kinins can produce redness, local heat, swelling, and pain. So kinins are potent pain-producing substance when applied to a blister base or injected intradermally. They elicit pain by stimulating nociceptive afferents in the skin and viscera. So the biologic actions of kinins are mediated by specific receptors located in the membranes of the target tissues. There are two types of your kinin receptors, termed as B1 and B2, and they have been defined based on the rank orders of agonist potencies. So for B1, this is actually the rank of your orders of your agonist potencies, and your B2. So note that they have B here. So the B here stands for bradykinin and not for beta adrenoceptor, huh? So bradykinin displays the highest affinity in most B2 receptor systems, followed by your lysine bradykinin and then by met-lysine bradykinin. So on one exception is your beta 2 receptor that mediates contraction of your venous smooth muscle. And this appears to be the most effective to lysine bradykinin. So your B1 receptors appear to have limited distribution in mammalian tissues. So the known functional roles for B1 receptors are limited. So B1 receptors may also be important in long-lasting kinin effects, such as collagen synthesis and cell multiplication, while your B2 receptors have widespread distribution. So the receptor or your beta receptors belong to G protein coupled family of receptors. And the receptor binding sets in motion multiple signal transduction events, including calcium mobilization, chloride transport, as well as formation of your nitric oxide and activation of your phospholipase C and phospholipase A2 and adenyl cyclase. So kinins are metabolized rapidly. So it has a half-life of less than 15 seconds by non-specific exopeptidases or endopeptidases, commonly referred to as kininases. So there are two plasma kininases that have been well characterized. So you have your kininase 1, apparently synthesized in the liver. This is a carboxypeptidase that releases the carboxyl terminal arginine residue, and your kininase 2, which is present in the plasma and vascular endothelial cells throughout the body. So it is identical to your ACE enzyme. So kininase 2 inactivates kinins by cleaving the carboxyl terminal dipeptide phenylalanine arginine. So bradykinin is almost completely hydrolyzed during a single passage through the pulmonary vascular bed. So there are some effects on your kallikrein, the effects of some of the drugs on your kallikrein-kinin system. So considerable effort has been directed toward developing a receptor antagonist. So since such drug has a considerable therapeutic potential, like being an anti-inflammatory and nociceptive agents. So you have competitive antagonists for both B1 and B2 receptors, and they are available for research use. So an example of your B1 receptor antagonists are your leucine 8, DES, arginine 9. So they are all still under research. And then you have your non-peptide B1 receptor antagonists, but these are still not available. So the first B2 receptor antagonists to be described or to be discovered were also peptide derivatives of your bradykinin. So these first generation antagonists are used in animal studies of your kinin receptor pharmacology, but their half-life is short and they are almost inactive in human B2 receptors. So you have your icatibant or icatibant. So these are second generation B2 receptor antagonists. So they are orally active, potent, and selective, and it has a long duration of action, more than 60 minutes. So it displays high B2 receptor affinity in humans and all other species in which it has been tested. So in animal studies, it will block exogenous and endogenous bradykinin, and in human studies, it is evaluated. So the role on its role in pain, hyperalgesia, and inflammation management. So the third generation B2 receptor antagonist was developed. So the examples are your FR173657. So wala pa itong mga pangalan, so that's why it has given a code. So you have your FR1732357 and NTC18884. So these are all investigational pa. These antagonists will block both human and animal B2 receptors, and they are orally active. So they have been reported to inhibit bradykinin-induced bronchoconstriction in guinea pigs and carrageenan-induced inflammatory responses in rats and capsaicin-induced nociception in mice. So in animal studies pa lang. So the synthesis of your kinins can be inhibited with the kallikrein inhibitor aprotinin. So your actions of your kinins mediated by prostaglandin generations can be blocked non-specifically with inhibitors of prostaglandin synthesis like your aspirin. Conversely, the actions of your kinins can also be enhanced by your ACE inhibitors, which block the degradation of peptides. So if you have inhibition of your bradykinin metabolism by ACE inhibitors, this will contribute significantly to their antihypertensive action. So there are already evidences that by acting on B2 receptors, bradykinin will play a role or play a beneficial protective role in cardiovascular disease. Selective B2 antagonists, or agonists, are available, and they have been shown to be effective in some animal models of human cardiovascular disease. So these drugs have potential for the treatment of hypertension and myocardial hypertrophy. So vasopressin is an antidiuretic hormone, and it plays an important role in long-term control of blood pressure through its action on the kidney to increase water reabsorption. So it also plays a role in the short-term regulation of arterial pressure by its vasoconstriction action. It also increases total peripheral resistance when infused in doses less than those required to produce maximum urine concentration. So such doses do not normally increase arterial pressure because the vasopressor activity of the peptide is buffered by reflex decrease in cardiac output. So when the influence of this reflex is removed, like in shock, if you have pressure sensitivity to vasopressin, this will be greatly increased. Now, pressure sensitivity to vasopressin is also enhanced in patients with idiopathic orthostatic hypotension. So at higher doses of vasopressin, it will increase your blood pressure even when the baroreceptor reflexes are intact. So there are three subtypes of vasopressin receptors that have been identified. You have your V1A, V1B, and V2. V1A receptors mediate the vasoconstrictor action of vasopressin. Your V1B receptors potentiate the release of your ACTH by the pituitary corticotropes, while your V2 receptors mediate the antidiuretic action. So V1A effects are mediated by activation of phospholipase C, formation of inositol triphosphate, and increased intracellular calcium concentrations. Wait lang ha. Hello? Kung ano kan doktora kuan Santa Maria assessment? Ano? Sige, dagdag kayo may dapo lecture. May dapo lecture dali. Ika-lecture ako. Ano official nga x-ray? Ano official nga x-ray? Ano official nga x-ray? Ano? Pneumonia. Waray TB, YTB. Waray, okay, sige. Kuan, hypertensive cardiovascular disease, chronic atrial fibrillation, in rapid ventricular response, heart failure, stage 2, stage C, with preserved ejection fraction. Functional class 2. Class 2. Tapos, community-acquired pneumonia, moderate risk. Ang kanduktora Sigli, ano? Sige. Tapos, ang sunod na diagnosis ng CAP moderate risk, hypothyroidism, secondary to total thyroidectomy. Sige daw, go through daw.
So,
Wala din naman ito ako na kung siya na si Rin. Hypertensive cardiovascular disease. Diba na sa'yo po hypertensive cardiovascular disease?
Hypertensive cardiovascular disease.
Oo.
Aggravation and capillary response, heart failure, stage 3.
NYHA, kasi AHA, ito sa last stage 3. Heart failure stage 3 with preserved ejection fraction, functional class 2. Oo. Sige, thank you. Sorry ha, damot mga isturbo. Where are we? So your V2, the V2 effects are mediated by activation of your adenyl cyclase. So vasopressin-like peptides, selective for either vasoconstrictor or antidiuretic activity has been synthesized. So the most specific V1 vasoconstrictor agonist synthesized to date is your PHA, ILE3, and your ORN8 or vasopressin. So this is actually the biochemical structure of your vasopressin. So your selective V2 antidiuretic analogues include your 1-deamino arginine vasopressin and your 1-deamino arginine vasopressin. So your DVD8BP. So they have specific antagonists of the vasoconstrictor action of your vasopressins. These are actually available. They are also available. Your peptide antagonists, your mercaptocyclopentamethyl methylene propionic acid 2, or your arginine, otherwise known as your arginine. So your vasopressin also has your anti-oxytoxic activity, but it does not antagonize the antidiuretic action of your vasopressin. So orally active V1A receptor antagonists have also been discovered, and these are your OPC21268 and your SR49059. Now your vasopressor antagonists have been particularly useful, or it has an important role that vasopressin plays in the blood pressure regulation, like in situations where you have dehydration or hemorrhage. So they have also potential for the treatment of hypertension and heart failure. The natriuretic peptides, so they are actually found in your atria. So your atria and other tissues of your mammal contain these peptides. So you have your natriuretic, diuretic, and vasorelaxants and other peptides. So the family consists of your atrial natriuretic peptide or your ANP and your brain natriuretic peptide or BNP and your C-type natriuretic peptide or your CNP. Now the structures of these three peptides are similar, but they have differences in their biologic effects. So for ANP, it is derived from the carboxyl terminal end of a common precursor termed prepro-ANP, which in humans is a 151 amino acid peptide. Three. So your ANP is synthesized primarily in cardiac atrial cells, but small amounts are also synthesized in the ventricular cells. So they are also synthesized by neurons in the central and peripheral nervous system and in the lungs. So your ANP circulates as a 28 amino acid peptide with single disulfide bridge that forms your 17 residue ring. So there are factors that will increase the release of your ANP from the heart. So the most important one appears to be the atrial stretch via your mechanoceptive ion channels. So ANP release is also increased by volume expansion, by head-out water immersion, or changing from the standing to the supine position and during exercise. So in its case, the increase in your ANP release is probably due to an increase in your atrial stretch. So ANP release can also be increased by sympathetic stimulation via your 1A adrenoceptors, endothelins via your eta receptor subtype, and glucocorticoids and vasopressin. Your plasma ANP concentration also increases in various pathologic states, including heart failure, primary aldosteronism in chronic renal failure, and in inappropriate ADH secretion syndrome. So your ANP will produce a prompt and marked increase in sodium excretion and urine flow when this is administered. So the GFR increases with little or no change in renal blood flow so that the filtration fraction increases. So ANP-induced natriuresis is due both to increase in glomerular filtration rate and a decrease in your proximal tubular sodium reabsorption. It also inhibits the secretion of renin, aldosterone, and vasopressin. So these changes may increase sodium and water excretion. So ANP decreases arterial blood pressure. So this hypotensive action, is due to the vasodilatory effect of your ANP, which results from the stimulated particulate guanylyl cyclase activity, with increased cyclic GMP levels and decreased cytosolic free calcium concentrations. So your ANP will reduce also the sympathetic tone to the peripheral vascular and antagonizes the vasoconstrictor action of your angiotensin II and other vasoconstrictors, which may also contribute to the hypotensive action of the peptide. So it also participates in the physiologic regulation of sodium excretion and blood pressure. For example, your suppression of your ANP production or blockade of its action will impair the natriuretic response to volume expansion and increases your blood pressure. So your BNP is isolated from the porcine brain, but like your ANP, it is synthesized primarily in the heart. So it has two forms, the 26 and the 32 amino acids, and it is released, appears to be volume related. So your BNP exhibits natriuretic, diuretic, and hypotensive activity similar to your ANP, but circulates at lower circulation. While your CNP, this consists of 22 amino acids and is located predominantly in the CNS, but is also present in other tissues, including the vascular, endothelium, kidneys, and intestine. So it has not been found in significant concentrations in the circulation. And CNP has less natriuretic and diuretic activity than ANP and BNP, but it is a potent vasodilator. So its physiological role is unclear. So the natriuretic peptides have a short half-life in the circulation. So they are metabolized in the kidneys, liver, and lungs by neutral endopeptidase or NEP24.11. Inhibition of this endopeptidase will result in an increase in your circulating levels of the natriuretic peptides, natriuresis, and diuresis. So the peptides are also removed from the circulation by binding to your ANPC receptors in the vascular endothelium. So this receptor binds the 3 natriuretic peptides with equal affinity. So the receptor and bound peptide are internalized, and the peptide is degraded enzymatically, and the receptor is returned to the cell surface. So administration of BNP as neseritide in patients with severe heart failure increases sodium excretion and improves your hemodynamics. However, the peptide has to be given by constant intravenous infusion. So a more promising approach may be use of drugs that will inhibit the neutral endopeptidase responsible for the breakdown of your ANP. So in patients with heart failure, they usually have high plasma levels of ANP and BNP. And this has emerged as an important diagnostic and prognostic markers in this condition. So plasma ANP concentration has been shown to be closely correlated with the New York Heart Association functional class of symptomatic heart failure. So the peptides will reduce salt and water retention. However, renal responsiveness to the peptides will decreases as heart failure worsens. So the natriuretic peptides may also play a role in preventing development of hypertension. For example, in experimental animals, they have identified an important role of peptides in preventing mineralocorticoid-induced and salt-induced hypertension. So your vasopeptidase inhibitors are a new class of cardiovascular drugs that inhibit 2-metalloprotease. So the enzymes are your NEP24.11 and your ACE. So this will increase the levels of your natriuretic peptides and decrease the formation of your angiotensin II. So what happens is that you will have an enhanced vasodilatation, reduced vasoconstriction, and an increase in your sodium excretion. And in turn, you will have peripheral vascular resistance and reduction in your peripheral vascular resistance and blood pressure. So what you have new vasopeptidase inhibitors, and these are your omapatrilat, your sampatrilat, and your fasidutrilat. So your omapatrilat is at the most advanced stage of clinical development. So they are all under investigation. So it lowers the blood pressure in animal models of hypertension, as well as in hypertensive patients, and improves the cardiac function in patients with heart failure. Your omapatrilat causes a significant incidence of angioedema in addition to cough and dizziness. But nevertheless, combined inhibition of your neutral endopeptidase and ACE with this class of drugs may be promising approach to treat cardiovascular disease, and further clinical trials are actually underway.
So the endothelium also has a source of a variety of substance with vasodilator and vasoconstrictor activities. So you have your PGI2, your nitric oxide. So your nitric oxide include the endothelin family. They are potent vasoconstrictor peptides that were first isolated from the aortic endothelial cells. So there are three isoforms of your endothelin, and these are your endothelin ET1 and two similar peptides, your ET2 and ET3. So its isoform is a product of a different gene, and this is synthesized as a pre-pro form that is processed to a propeptide and then to mature peptide. So processing to a mature peptide occurs through activation or action of your endothelin converting enzyme. So each endothelin is a 21 amino acid peptide containing 2 disulfide bridges. So endothelins are widely distributed. Your ET1 is the predominant endothelin secreted by vascular endothelium. It is also produced by neurons and your astrocytes in the CNS and in the endometrial, renal, mesangial, Sertoli, breast epithelial, and other cells. Your ET2 is produced predominantly in the kidneys and intestine. Your ET3 is found in highest concentration in the brain, but it is also present in the GI tract, lungs, and kidneys. So endothelins are present in the blood, but in low concentration. So they act locally in a paracrine or autocrine fashion rather than as circulating hormones. The expression of your ET1 gene is increased by growth factors and cytokines, including your TGF and your interleukin-1, and your vasoactive substances, including Angiotensin II, Vasopressin, and by mechanical stress. So the expression is inhibited by nitric oxide, prostacyclin, and atrial natriuretic peptide. And the clearance of your endothelins from the circulation is rapid, involving enzymatic degradation of NEP 24.11 and clearance by your ETB receptor. So endothelin has a wide or exert widespread action in the body. So it will cause dose-dependent vasoconstriction in most vascular beds. With intravenous administration, your ET1 will cause rapid and transient decrease in arterial blood pressure, followed by prolonged increase. Now, the depressor response results from release of prostacyclin and nitric oxide from the vascular endothelium, while the pressor response is due to direct constriction of your vascular smooth muscle. It also exerts a positive inotropic and chronotropic action on the heart, and they are potent coronary vasoconstrictors. So it also acts on the kidney, causing vasoconstriction and decreased GFR and sodium and water excretion. In the respiratory system, it will cause constriction of tracheal and bronchial smooth muscle. So it will interact with several endocrine systems, increasing the secretion of your renin, aldosterone, vasopressin, and atrial natriuretic peptide. So it also exerts a variety of actions on the CNS and peripheral nervous system, the GI tract, the liver, the urinary tract, the male and female reproductive system, eyes, skeletal system, and the skin. While your ET1 is a potent mitogen for vascular smooth muscle cells, cardiac myocytes, and your glomerular mesangial cells. So endothelin receptors are present in many tissues and organs. So it has two receptor subtypes, your ETA and your ETB. Your ETA receptors have high affinity for ET1 and low affinity for ET3, and they are located on the smooth muscle cells, and they mediate vasoconstriction. Your ETB receptors have approximately equal affinities for AT1 and your AT2, AT3. And they are located in the vascular endothelial cells where they mediate release of your prostaglandin I2 and nitric oxide. So both receptor subtypes belong to a G protein coupled 7 transmembrane domain family of receptors. So the endothelin system can be blocked with receptor antagonists and drugs that block your endothelin converting enzyme. Your endothelin eta or ETB receptors can be blocked selectively or both. They can be blocked with a non-selective eta ATB antagonist. So example of a non-selective antagonist is your bosentan. So this drug is active both IV and orally, and it blocks the initial transient depressor and prolonged pressor responses to intravenous endothelin. So the formation of your endothelins can also be blocked by inhibiting your endothelin converting enzyme with your phosphoramidon. So your phosphoramidon is not specific for endothelin converting enzyme, but several potent and more selective inhibitors are now available. So the therapeutic potential of these drugs may be similar to that of endothelin receptor antagonists. So systemic administration of your endothelin receptor agonists or antagonists or endothelin converting enzyme inhibitors will cause vasodilatation and a decrease in your arterial pressure. So intra-arterial administration of the drugs will cause a slow onset forearm vasodilatation. There are also evidence that suggests that endothelins participate in cardiovascular diseases, including hypertension, in hypertrophy, heart failure, atherosclerosis, and in coronary and myocardial infarction. They have also been implicated in pulmonary diseases, including asthma and pulmonary hypertension, and in several renal diseases. So this evidence includes findings of increased endothelin levels in the blood and an increased expression of your endothelin mRNA in endothelial or vascular smooth muscle cells, and its response to administration of your endothelin antagonists. So endothelin antagonists have a potential in the treatment of these diseases. So there are already clinical trials on bosentan and other non-selective antagonists, as well as eta-selective antagonists that have produced beneficial effects on the hemodynamics and other symptoms in heart failure, pulmonary hypertension, and essential hypertension. But currently, your bosentan is approved for pulmonary hypertension. And your endothelin antagonists occasionally can cause systemic hypotension and increased heart rate and facial flushing or edema and headache. So these are some of your adverse effects of the drug. The potential GI effects include nausea, vomiting, and constipation. It has also been known to have teratogenic effects. That's why your ET antagonists are contraindicated in pregnant patients. So I guess that's my last slide. Thank you for listening.